this program on MDS Connect. Actually, it's a really great honor for me to be here, mainly because I'm with two of my best friends and respected colleagues. We cannot say for how long we know each other, right? But let's say I know Dr. Carraway from the Cleveland Clinic, one of the leaders there since he was a fellow, I think, at Johns Hopkins. Yeah. And Rami, I don't know. We've been working together on MDS, also the three of us, for more than 20 years, I think. And both are like incredible leaders in the field, so it's really a great opportunity to be here. My name is Guillermo Garcia-Manero from MD Anderson Cancer Center, Carraway Komrokji from Moffitt Cancer Center, and Dr. Hathaway from Cleveland Clinic. I want to not only thank Peer Review for putting all this together, but also the support that you see there from Bristol Myers Squibb, Jeroen and Thai Oncology gave to do this program. These companies actually not only support the program, they actually support a lot of the research that happens in this field. And this is not, we're at ASCO, breast cancer or like lung cancer, right? So we are grateful for what you guys do, supporting our clinical trials and our research. If you have not done already, please, there is this pre-event survey that's quite important. Also for the local audience, there's also online audience, so we'll talk on the mic and we'll go slow and follow kind of the rules that we have there. There will be some additional polling during the presentation, and hopefully I will not make mistakes there. There are these iPads where we'll be grateful if you can submit your questions. And if any of you have a question from the floor, please go to the microphone, because this way people that are online can hear you. For those that are in the room, you have this personal device, and you should scan this QR code and with the following slides to respond to the polls. I think there are 2 or 3, if I recall correctly. And then again, for those that are virtually connected online, please do the same things. This is basically just to give you a little bit of encouragement. If you participate, you will win this like $50 gift card. So please think about this. And all the contents from this program are online. And again, you can get them through this peerreview.com/2026 MDS. And I guess if you go through that QR code, and you see a couple of emails there that you can use to ask for the slides and the data. And with that, we're going to slowly go into the presentation itself. You will see that there's going to be a mixture of real-world data, also some of the presentations at ASCO, of course, embargo, but some ideas about what's going to be presented at the meeting during the long weekend here at ASCO. So this slide is actually important, and this is something that leukemia doctors talk all the time, not just MDS. Should we use our best drugs up front or in second, third line? Some people say, well, maybe it's better to just have the best for the last. We tend to think, no, perhaps the most effective medication should be used up front. And the slide kind of shows this. You see the responses, how they drop from first line, second line, third line, and then this becomes like really particular disease. I have to say that when I teach my fellows about MDS, I said there's this kind of condition of what we call HMA failure, low risk, we don't call it HMA failure anymore, like low risk failures, like a bone marrow failure, 3-4 lines of therapy, no blast, right? Sometimes not even dysplasia, but total bone marrow failure. The patient is not a candidate for transplantation because they're older, and you're really in a difficult situation. So this idea that moving these drugs a little bit earlier helps is probably really the thing to do. And then on the table, you see actually the impact on survival. We're talking like 55 months versus 11 months, things like that. So quite drastic. And then something that I never understood, and you will think, well, he works on MDS at MD Anderson, he should learn about this. So for many years, we had this kind of slides, right? Like, okay, if you respond, you are less transfusion dependent, etc., you should do better. It's kind of logical. But I thought it was kind of like a tautology, like a circular kind of concept. Well, you're responding, you do better. But this kind of data, this is actually now relatively old by Luca Malcovati and some other people in Europe, showed this phenomenon, that there is something to attaining a response. And that response then translates into better overall survival. And you will see an example from one of the trials with luspatercept in a few minutes. So there may be more to the biology of the disease and this issue of really minimizing anemia, minimizing transfusion dependency, that could somehow affect the natural history of the disease. And to me, this is very important because leukemia doctors like to kill cells, right? You have this mutation, you give this drug, you kill it, we count blasts, cytogenetic responses. And now we are in some situation where you have these drugs that are kind of, maybe some of them even potent anti-inflammatory agents or maybe telomerase inhibitors, etc. And they may or may not have a really powerful anti-leukemia effect, but somehow they're able to restore hematopoiesis, and that results in an improvement in survival. So I'm actually quite interested on that phenomenon. So today, I think that our objectives are that and I say that, and I forgot to mention that earlier, this actually kind of like should be like a forum for discussion. So it should be quite didactic, and it should be quite interactive, meaning like, please, any questions, comments from people inside and outside will be really appreciated, like a town hall type of model. So we will learn that modern therapies can really improve transfusion independency rates in MDS-related anemia. Remember, this is the most important cytopenia in this disease. We're going to be talking about updated guidelines and evidence basically to reshape the frontline, and very, very important today, the sequential use of the drugs that we have. Rami and I always joke that for years we work in high-risk disease. Nothing's happening there. And meanwhile, on the left side of the field, like in low-risk disease, all this development, right? That's like, okay, how did this happen? Maybe we should not get involved in this, right? And let things like flow. You know, slower progress in high-risk MDS, I challenge you that. You know, we say, oh, the AMLs are doing so fast, but all the drugs are actually first approved in MDS and then later on approved in AML. We just saw that with the oral decitabine, cedazuridine, venetoclax, right? Mm-hmm. Drug approved 4 or 5 years ago for patients with myelodysplastic syndrome. Now, in AML, if you have a mutation, that's a different story, right? That's where the progress is. And unfortunately, we don't have those kind of mutations in myelodysplastic syndrome. And then, you know, ASCO is a big meeting, a lot of community colleagues. I admire them. I don't know how you can treat breast cancer, lung cancer, and then go and be expert on MDS. But there are some issues in terms of optimizing how you use the drug, doses, etc., that may not be that straightforward if you don't really treat myelodysplastic syndrome all day long. And with that, and almost 2 minutes ahead, we're going to start with the first part. We're going to have 3 sessions. I think each one is 20 minutes. And I have the honor to start with the first one. So I'm going to be talking about what happens in low-risk MDS. So again, these are some of the questions in this town hall type of approach that we want to have today. And these are very specific for anemic low-risk MDS patients. So the first one is, what strategies do you use to treat transfusion-dependent and very low-risk MDS? The second question is, should a patient with a stable transfusion dependency, I guess someone that gets a transfusion once a month, be viewed as an acceptable disease control? I will argue, you know, immediately that probably that will not be or should not be our goal. And then how long do you persist with transfusion support if the burden remains stable? So this is actually interesting, right? Like, patient is stable, you have these transfusions, you have these new agents, how do you move them, and what do you ask from them? The second questions in terms of first-line treatment of and selection in patients with anemia low-risk MDS are shown here. So what will be your decision in terms of the therapeutic that you want to use? ESA, luspatercept, imetelstat. Very important question after. Now we understand this kind of phenotype of the disease, or genotype in a way, of ring sideroblastic anemia. I'm going to, because I'm 2 minutes ahead, I'm going to tell a joke. When Rami and I, many years ago, I don't know if you were on that steering committee, we were designing the Medalist trial, and it was a NASH. And the leader of that comes and says, oh, we're going to do this in ring sideroblastic anemia. So I raised my hand, I said, excuse me, that disease that doesn't really exist. I've never seen a case. So the guy says, what are you talking about? We thought you were the MDS expert at MD Anderson. So I said, well, you know, this is actually before 2014 when the C3b1 gene was discovered. So like, yeah, I don't know. This is maybe 1% or something like this. They were looking at me like, he has no clue. So then I go home and I call our chief hematopathologist, Dr. Ramos. I never told you this joke. Okay, this is a true one, actually. So I said, Carlos, what's happening? I go there, these Europeans, this is like a European thing, I'm from Spain. Like they have RS-positive disease. And he says, no, we never thought this was important to report it. So the MD Anderson pathologists never really, we're talking 15 years ago, was maybe hidden, some letter underneath. They didn't really care. They didn't think this was actually important because there was nothing actionable. There was nothing like we did. Now, a couple of years later, SF3B1 mutation associated with RS-positive disease, and now the biology becomes really interesting, and now we have these drugs that really work very well in this context, right? So it's actually kind of fascinating how these things work. Probably Moffitt knew about RS positivity like 50 years ago. Anyways, but this is actually a true story. So now we're in this dichotomy of separation of RS-positive disease versus RS-negative disease, and what is your choice of therapy? And you will see that there is not 100% alignment between the three of us, I'm not sure. And then there's questions in terms of how you dose these drugs, right? We have this kind of FDA-mandated escalation of the dosing of the luspatercept. Will it make sense to use higher doses, etc., if you had a more rapid response? And then particularly with luspatercept, you see this phenomenon occasionally. We see that more in second-line, heavily transfusion-dependent patients of fatigue. And this sometimes can be complicated because you see a patient with great response, 12, 13 grams of hemoglobin. You say, okay, wow, you're amazing. And the patient is kind of tired, right? So this is another issue. And I've learned actually about this from Rami in terms of ways to mitigate this kind of issue. Here we put kind of like a simplified version of what we were talking about earlier. And I think when you're assessing your patient with low-risk MDS, again, this issue of RS positivity versus RS negativity is quite important. Majority of the patients with ring sideroblastic anemia have a mutation on this SF3B1 gene. Now, this SF3B1 gene is not an homogeneous gene. Some of the mutations, particularly something called K700T, have really, really good prognosis. This is what we see in true RS-positive disease. Some of the others actually are not that good, and Rami has published actually on this. So for the RS-positive, that most of the times has the SF3B1 mutation, although sometimes you may not find that mutation, but they have the clear phenotype of the disease, meaning, if you do an iron stain, that's what they were not doing at MD Anderson, and you see those cells, then in that particular context, luspatercept probably is the preferred category 1 agent, and you will see why in a minute. This is an extremely active compound in that context. Now, this is actually a minority of the patients with low-risk MDS and anemia, so this is not the majority of them. And then you have imetelstat, a drug approved a couple of years ago with a very interesting kind of different mechanism of action through modifying telomerase activity that has significant activity also in this disease, that is actually recommended to a very smart issue in the way the IMerge clinical trial was designed that allowed patients with high EPO level, like people that we know are not going to respond to ESA, and that actually were excluded from the registration trials of luspatercept. So we don't have data in people with an EPO level more than 500 with luspa, and of course ESAs will not really be very effective there. So for the RS-positive disease, that's very clear. Where there is a little bit more dilemma, and I guess we'll be discussing this, is in the RS-negative. That is, bulk of patients with low-risk MDS. And of course, we're excluding those with the del(5q) alteration. Remember, this is a very specific disease, highly sensitive to lenalidomide. Indeed, it's amazing to me that no company has tried to develop a second-generation lenalidomide, right? I don't know why. Maybe someone here can think about this. But this is disease that has really great drug with really amazing responses. So we're not talking about that here. So this will be RS less than 15% or no mutation. And then here, you talk about this dichotomy again of EPO level, less than 500, more than 500. So if you're in an upfront, remember we're talking about first line, relatively low EPO level, then the question is, will you use luspatercept or you will use ESA as your choice? And then if you're looking at the box in the middle, and maybe I can use the pointer here, you will see this magic number of 200. I think we were trained on 500, right? But more and more, we understand that 200 is perhaps the threshold for EPO level where these ESAs don't really work. And then you have the situation of patients with a high EPO level, more than 500. Again, very rare, and again, Dr. Komrokji taught us about this because he has really made analysis on this. Not very frequent, but probably the type of patients that we see in academic centers like Cleveland Clinic and so forth, that are difficult to treat, right? No data with luspatercept, not good data for sure with ESAs. And here what you will see is that there is some data, particularly in younger patients with some specific features that may respond to a plastic anemia-like therapy, like ATG. Dr. Komrokji uses that quite a bit. And then for those that are really not candidates for ATG-based therapy, that's where imetelstat is actually on label. And of course, what the three of us do, that is a clinical trial. Now, around 5 years ago, we had the first approval of luspatercept. Was the medalist in second line. New England Journal paper, plenary attached. We felt like MDS kind of came to being existent. And then we followed that very quickly with the COMMANDS trial. So what is COMMANDS? COMMANDS is the registration trial of luspatercept in first line for transfusion-dependent anemic patients with low-risk MDS. And that was a big international effort, randomizing luspatercept versus ESA. And the reason actually we used a threshold of 500 of the EPO was to be fair to the EPO. Like we felt like if we were just going to allow any EPO, and then you had all these patients that you knew they were not going to respond to ESA, people will say, well, okay, you're just playing to win, and not. So we decided to cap that study with an EPO of 500 just to give a chance and be fair to the ESA. To make a joke, if we were in CLL type of clinical trials, probably we just use chlorambucil or something like this, and we don't care about the EPO. No, here we try to be like kind of fair. But this was a very, very important study. It used modern techniques in terms of how we define transfusion dependency, what the criteria that we use for responses. I really love the concept of a response here. So a responder was someone that had not only transfusion dependency for 12 weeks, but also an increase in hemoglobin of at least 1.5 grams. So you have this dual endpoint of response. Traditionally, we just wanted mitigation of the transfusions. Here, a responder had to have a significant increase in hemoglobin. As you see there, the response rate was 76% versus 55%. So very, very clear. But to me, that was not the attractive part of this. The attractive part is on the table. That is the duration of the response, what I call the quality of these responses. The duration of the response, once these patients responded, is actually quite incredible. It's double, 126 weeks. We're talking now people that are transfusion dependent with increasing hemoglobin going for 3 years. We have these patients now 3-4 years on this therapy. So this is actually quite important. And this is going to be updated on Monday on a poster. It was actually presented as an oral last year at this ASCO meeting and then subsequently at EIHA, something that I find that is fascinating. So when we designed the COMMANDS trial, this was actually done very well by the sponsor, BMS. We're thinking, what are the endpoints that we want to look? Of course, transfusion dependency. That's the approval by the authorities, by the FDA and the EMA. But let's look at other endpoints. And we started talking about survival. And I remember the investigators were survival. How can a drug like ESA or luspatercept improve or not survival? But we thought, well, we have examples, right? JAK inhibitors in myelofibrosis that with time improve survival. Why not? And then with enough follow-up at ASCO last year, and it's going to be updated at the meeting on Monday, we started to see this phenomenon that this survival curve separates. Now, this is not a post-hoc analysis. This is actually a pre-planned analysis, but it's not the primary endpoint. In other words, we did not design COMMANDS to prove that luspatercept improves survival. This is a secondary endpoint that clearly shows that these survival curves demarcate. Now, I think this is extremely important because it started to show that the use of these drugs up front may really somehow start changing the natural history of the disease, right? And then for people like us here, start thinking, wait a minute, what would be the next combination? If the response rate is 70, what happens if the response rate will be 90? Can we actually start really changing the behavior of this disease? Now, the slide doesn't show something, that the rate of progression from low risk to high risk was also decreased. So somehow there's kind of a deceleration of this disease with this kind of therapies. And the question is this unique to luspatercept? If you put any other drug up front with a very strong response, will you see the same phenomenon or not? So we really need to understand how this works. But to me, this is very important. Now, as another joke, I am concerned that the FDA will start saying you need to do survival phase 3 registration trials, and then we will never really develop a drug in MDS anymore. But I think this is very important because if I was a practitioner in the community, I said, okay, these drugs may be better or worse or whatever, similar, but I saw this kind of data, I will be inclined to use a drug that shows this kind of survival curve. I really think this is important. And if you look at the box down here, we're talking about not reached to around 46 months or so. Now, they are together, and this is actually what you expect, right? These patients don't really transform to acute leukemia. You don't expect them to really die very quickly from the disease, and slowly they go and they separate. I was really fascinated by this, and I would like to see the paper with this actually out in a good journal pretty soon. There is also, going back to the very first slide, of what we call like early intervention. It was presented by our colleague Valeria Santini at ASH a few months ago, that I thought it was kind of interesting. And this, Rami, help me, I'm not sure if this was pre-planned or not, I don't really remember, but this was a very important presentation looking at patients that were on commands, transfusion-dependent, low risk, but they had a hemoglobin of around 8 or so, or they had what we call a low transfusion burden. This is a term that we kind of invented with the medalists, right? More or less than 4 units or something like this. We never used this kind of terminology, high transfusion burden, low transfusion burden. So what Dr. Santini from Florence, a great friend of us, showed at the meeting, and I think this data hopefully will be published also at some point this year, is that for those patients with kind of an earlier stage of the disease, so less anemic, less transfusion burden, the response rate with luspatercept on this command side is reaching 90%. And this is kind of incredible. And you will expect then that these patients will remain transfusion dependent for a long period of time. Now, I think this is one of the questions that you guys need to go to the QR and see if you can answer it. And the question here is, I think, quite provocative, but is how proactive are you about maintaining hemoglobin of 10 grams when managing patients with low-risk MDS and anemia? And then after you guys vote, I'll tell you a joke that I thought it was good. Not a joke, actually, a true clinical case. But anyways, if we can vote. I guess I'm going to read them for the people that are not in the room. So very proactive whenever feasible, someone proactive depending on symptoms, primarily focus on transfusion reduction. I do not generally target a specific hemoglobin threshold. Okay, so a majority of you, I talked too early, still a majority. So most, I guess I will wait. You let me know when we can move the slide. We can? Okay. So I think that that's the goal that we're starting to reach. And the anecdote that I'm going to tell you is not really a joke, is a patient of mine on the Elements trial. This is the study for transfusion-independent low-risk MDS anemic. Patient asked me, "Doctor, what is your hemoglobin?" This one you've heard before. I said, like, "What do you want to know?" I said, "Yeah, why mine has to be like less than 11 or something like that on this trial?" So I said, "Mine is like around 15. So it's like, why I cannot be 15? I don't know. So this is actually quite important, because I guess you will do much better if we were able to maintain a little bit higher hemoglobin levels. I need to pass the slide. Okay, I'm doing something wrong here. Anyways, this is actually quite important because what happens is, as you know, when you use luspatercept, there's this kind of step-by-step dose escalation. 1.33, 1.75. The drug is every 3 weeks. You do 2 doses, and then you decide whether you stay at 1 or 1.33. Now, this is FDA mandated. And Rami and I were part of very early studies with a similar compound. And the FDA was like, no, we have to be careful, we don't cause strokes and things like that, which actually I totally respect. But the reality is that we live with 14, 15 grams of hemoglobin, much better if we have 8 or 9. So this is actually becoming an important question. Let me see, because I got distracted now. Okay, we did that, perfect. And then again, there's this issue that the survival depends, this is real world data, on your threshold of hemoglobin. So as you see there, those patients that had more than 10 grams of hemoglobin, they do much better than those that have 8 to 10 and less than 8. Now, this is real world data. This is kind of retrospective type of analysis, but it suggests that you will do better if you were close to the physiological level of hemoglobin. And this actually somehow brought this study that I believe is going to be presented at IHA, not here, right? That is the Maxillos. So this is a very interesting study. So here were these investigators, I think, Rami, you're part of this, the Maxillos Yeah, we're not at MD Anderson or Cleveland Clinic. But this is a study basically saying, can we start with the full dose as opposed to have to do 133, 1.75? Can we go to full dose? I, to be honest, was not super excited about this because runways. If I start at the higher dose, what happens if I have 12, 13 grams of hemoglobin and I keep stopping? But hopefully the authorities will see that maybe we could at some point escalate that. And indeed, as you know now, with luspatercept, we can dose up to 12 grams of hemoglobin. No, we don't need to stop at around 11, 11.5. Now, these are some cases that we put together, the three of us, with trying to illustrate what we just discussed. So, woman with 72 years of age who comes to you with lower risk disease by IPSSR, good performance, she's tired. And then, testing shows low ring seroblast. She does not have a del5Q, no SF3B1, low blast, and this person is transfused 2 units every 6 to 8 weeks. And then you see there an EPO level of around 320, and I think that's actually kind of the key issue in terms of the decision. The Y count is okay, the platelets are okay. So then the question is, what would you do in this particular case? If it was lower than 200, maybe an ESA will be something that some of us will consider, but this is an EPO level more than 200. The data from the command shows that luspatercept in first line is actually a much more active compound than an ESA. So this is the next question that we have here. And again, you have to go and click. So for this patient, what frontline strategy, remember the 72-year-old lady, RS negative with an EPO level of 320 with progressive fatigue, you think it will be the best? Luspatercept, ESA, clinical trial, or hypomethylating agent-based therapy. So we can vote, please. Perfect. So the majority of you, I guess because of the hypo level, voted for luspatercept. This is what we will do at MD Anderson. Indeed, actually, at MD Anderson, we'll do that even if the hypo level was less than 200, but I thought that was the right question. Hypomethylating agents, something that we don't really do that much in frontline disease anymore. Now, to finish, in the last couple of minutes, anemia is not all in low-risk MDS, right? So you will see patients with thrombocytopenia, you will see patients with neutropenia, or actually significant bilineal or trilineal cytopenia. Right now, the best option for those patients will be a clinical trial. The three of us actually built our careers actually on these hypomethylating agents in MDS, so lots of data with azacitidine, the decitabine now, the new oral hypomethylating agents. And then again, there may be some patients that may benefit from immune modulation. At MD Anderson, those are like what we call hypoplastic myelodysplastic syndrome, but other centers like at Hopkins, NIH developed some formula that may allow you to predict specific subset of patients that may respond to this kind of approach. And just to finish, a couple of anecdotes. This is actually a very large study that the three of us led and was presented at ASH not too long ago. We're kind of finally submitting the paper, actually showing the value of these hypomethylating agents in frontline low-risk MDS. And you see in the here on your right that 5 days azacitidine improves survival in transfusion-dependent patients. Now, the issue with this study is IPSSS, really all response criteria, totally, unfortunately, antiquated because the time it takes to really read this study. So the question is there a potential role for a subset of, for hypomethylating agents in a very specific subset of patients with low-risk MDS? So we need to really think about this. And of course, this could be really stimulated by the development of these oral hypomethylating agents, right? We have the original oral azacitidine, but the next generation compounds are combined with cedazuridine, that is a cytidine deaminase inhibitor. This basically allows you to absorb this drug. So we now have an oral decitabine approved, actually last week in AML with venetoclax, in MDS now for many years, and hopefully we'll have an oral azacitidine that's already approved at some point in the next couple of years. But it may be a possibility for oral interventions with the hypomethylating agents for very specific subsets of patients. And with that, perfectly on time, I would like to pass it to Dr. Komrokji. Thank you, Rami.
Thank you. And good evening, everyone. Thank you for coming. Thank you, Guillermo, for the kind introduction. Peer review for putting this together. So I have two disclaimers. The first, that we three of us met when we were in our 20s. So given he gave, like, we've known each other more than 20 years. And the other disclaimer is, like, women are always smarter than men. Like, I'm sitting there, I cannot see the slides, obviously, because of my height. I was giving this talk in place like that, and I kept jumping. And then the girl came after me, and she just did like this. I was like, oh, like, you know, so you're smart. So anyhow, so I think Guillermo set the stage for me. I'm probably going to try to touch on the sequential treatment. And I think sometimes we do have a little bit differences in how we think of this. But one thing to say also actually is, like, what we do in practice is a little bit different from what the clinical trials are done. All our trials are based on transfusion independency. Like, you know, talk to three of us, I talk to our colleagues in Europe, nobody waits till the patient becomes transfusion dependent. So sometimes even when we're having this debate, luspa versus ESA, we are not talking even probably at the case that Guillermo presented, that the patient is needing blood. And if the patient biology is that he needed transfusion dependent from the diagnosis, that's a different biology. So most of the time we are starting ESA, or even if we can luspatercept actually before the patients are transfusion dependent. Hopefully the element will answer that. But that's the difference from what we extrapolate from clinical trials to real life, that in real life, once patients are symptomatic, obviously, below probably 9, at least in my practice, I'm thinking to start ESAs. I think if somebody comes highly transfusion dependent, probably ESAs are really not effective therapy. So, and again, I think we start with some of the questions that were by the audience. And how concerned should we be? Persistent anemia, ongoing transfusion burden, ESA refractory, and what's the impact of uncontrolled anemia? Obviously, it is concerning. Transfusion dependency per se, as Guillermo showed, is predictor of bad outcome, mostly reflecting biology of the disease, right? So somebody have more further bone marrow failure, but they also probably over time will have sequelae of the iron overload. We've looked at, in a way, like how patients respond to each line of therapy, and patients that have failure of first and second line of therapy actually have very poor outcome, to a point sometimes in our practice now, if somebody had 2 or 3 lines failure and then the younger side, I think there is a role of transplanting those patients because the likelihood of them responding to something else is low. The other questions, you know, probably are like, again, which is a huge debate in the field, is how do you sequence those treatments? You know, which treatment options do you consider for patients with lower risk after luspa failure? How do you sequence ESA, luspa, emtilistat? And in ESA refractory, how much weight do you place on serum EPO? So I probably will tackle the last one. Historically, we looked at EPO up front for those patients. And in reality, when you look at the community data, like most of, you know, community oncologists don't think of it, don't, you know, check it. Sometimes it's easier just to start the patient and see how they are going to respond within a month or 2. We historically did not look at serial monitoring of the EPO. Like, we checked it at baseline to decide ESA or not. I think with a lot of the evolving data, maybe there is a role of like starting checking it at certain time points as a, you know, distinguisher for the response. Obviously, we have, you know, 3 options now in addition to the hypomethylating agents. As Guillermo said, I think we all agree that we always try to push the hypomethylating agents as our last resort, or if patients' concomitant cytopenias force us to use the hypomethylating agents, or we are seeing higher risk features. So we have ESA, luspa, emtilistat, and how to sequence that is really not an open question a little bit. I think, you know, the way to think of this eventually is going to be this totality of the therapy. And, you know, we've talked about this many times. It's like, once a patient is transfusion dependent, actually, people think, even RS positive, that like when you do the IPSSM, they have 10-year survival. But that's not true if a patient is transfusion dependent. Even an RS positive transfusion dependent, the survival comes down to 50 or 60 months. We are talking 4 or 5 years. Non-RS, it's coming to 3 to 4 years. So those patients have a journey of, unfortunately, 4 to 5 years or 6 years if they are not going to transplant. And the question in that part, or in that journey, if I sequence those therapies, what's the best way? And it may not be a straight answer for every patient. A patient may benefit from sequence A, B, C. The other patient may benefit from B, C, A. Depend on the characteristics of the disease. I'll try to show some data, at least currently, how we sequence that. But that's obviously an evolving therapy concept. And if the element, for example, shows us that it's okay to treat before transfusion dependency, I think we are going to shift treatment, we can say maybe shift to the left treatment and start that earlier, but that will also change how we sequence those therapies for those patients. All right, so patient with imetelstat on early treatment, early cytopenia, how do you distinguish expected on treatment from disease progression? I think temporarily, obviously, if cytopenia happens early, that's probably treatment. Most of the patients with lower risk MDS, if they progress, is over time. I'll show some data that actually the cytopenia on treatment with imetelstat does correlate with outcome for those patients, similar to the story of lenalidomide in DEL5Q. Typically, cytopenias related to imetelstat happen within the first and second cycle. Like, it's rare to see it after that. If I had a patient that was responding nicely on cycle 7 and now I see cytopenia, that's different from somebody early on, similar to lenalidomide, similar to JAK2 inhibitors and MPN, etc. Older patient, ESA refractory, RS negative, lower risk MDS with anemia-related fatigue. Would you start imetelstat at full dose or consider starting lower dose? We actually get asked this question often. I typically have started the full dose because the data support that. There are people talking about lower doses, but I think that's a study, and this is a requirement by the FDA that there will be studies looking at starting at a lower dose. In my practice, I still start with the higher dose. I think you just have to be monitoring things in the first 2 months closely. If somebody develops cytopenias, wait, not start the next round. Dose adjust. And with that approach, and I'll show you at least a sneak peek on some data we'll be presenting at EHA, that in our hands, that's been safe. I've had colleagues that actually had started lower dosing, but there is really no data on that. All right, so we'll start with a question that needs the scanning. In ESA refractory lower risk MDS, what most strongly drives your next line of therapy? Serum EPO level, prior luspa exposure, SF3B1 ring sideroblast, or degree of transfusion dependency? So this is ESA failure lower risk MDS. All right, so mix of things, obviously prior luspatercept exposure, magnitude of transfusion burden, EPO level, that's actually emerging as something we look at in second line. So I think all of them probably would factor as you selected all those answers. So, all right, so I think Guillermo set the stage for the upfront treatment. This is more like now going into second line, thinking of the second line after first line therapy failure. So for patients with RS negative, which again, as Guillermo mentioned, they are the majority of the patients. Actually, RS positive is like 15%. They do have a little bit higher prevalence because their outcome is better, and that's why you've seen this bias or like more patients going on trials with RS positive because they accumulate in our practice. But in reality, it's only 15% of the patients. RS negative. So if patients, after first-line therapy failure, like EPO was less than 500, and they had no response to ESA. So I think your options depends on what was the first line. If patient obviously had luspatercept, that's not going to be a second-line option. Imetelstat will be probably the most likely option. People talk about using ESA alone after luspa failure. There is really not much data. There is a small subset from Dr. Sequeira's real-world data showing maybe 25% responses, ESA alone. There is data from the French group in a study context called the Combola, where they actually add the luspatercept. They do actually add the luspatercept after the ESA failure if they had ESA. So we don't have that information or that data. So if patients had luspa up front, most of the time we are going to go to emtilistat. Maybe like some patients would respond to ESA, but again, it's very handful data. If patients had ESA, then again, you have the option of either. But again, in RS negative, we don't have much data on luspa as second line. The medalist study that I'll go through was in the RS positive. But some people would say if patients have other cytopenias, it's relatively reasonable to try that. And the NCCN guidelines say if it was not previously used, you can use it. If the EPO level is more than 500, then again, that will exclude like the probability or the high chance of response to either luspa or EPO. And then you are going to be left with emtilistat, which is preferred. Hypomethylating agents, as I think most of us would say, that we would use them if patients have platelet count or neutrophil count that will not allow me to use emtilistat. In RS positive, I think it's a little bit becoming more straightforward. I think there is almost a 100% concordance between everybody that like luspa is probably the first line option for patients with RS SF3B1 positive. At time of treatment failure, I think emtilistat is category 1. Patients with MDS SF3B1 tend to have good platelets and neutrophils and less chance to progress to acute myeloid leukemia. So many of those patients actually will be eligible for the emtilistat. There will be no problem with their platelets or neutrophil count to get that. If the EPO level is high, emtilistat is preferred. It's interesting that the NCCN guidelines put luspatercept as an option in the second line if the EPO was more than 500. This is based on the medalist study that did not have a cutoff of the EPO. As Guillermo nicely explained, like when we did the commands, we did that cutoff to protect the bias against ESA. But then it ended that actually neither of them worked pretty well above 500. And with the newer drug, elritercept, it's also the same cutoff. But then the medalist study, there was no requirement. There is a small number of patients, and there were some responses. But again, they are not high. But the NCCN guidelines give that option. So ESA obviously historically have been our mainstay. And we typically recommend doing 8 to 12 weeks. If you look at collective data, probably somewhere between 30 to 40% of the patients would respond for an average a year to a year and a half max, and then they will lose the response. And obviously, they are pretty commonly used in the community. There are like now also the biosimilars of them that are pretty cheap. But we see this kind of ongoing use of ESAs regardless. And sometimes, I've had patients like their hemoglobin was 8, they start on ESA, and it's ongoing. And then I say, like, why you are continuing the treatment? It's like, oh, it's not worsening my anemia. But like you started with 8, and it's not changing. Or we see that the patients go on the second, third line of therapy, and the ESAs are ongoing for that. And Eva Helmstrom had published this years ago, a simple model. If patients are needing blood or their EPO is above 500, either of those, their chances of response to ESAs are less than 10%. And in real life, the way we use it, we don't use it in somebody who's transfusion dependent. We use it in somebody who has symptomatic anemia, their hemoglobin is drifting, 8.9, EPO level is maybe below 500, and as Guillermo mentioned now, maybe even below 200. I have no problem starting the ESAs. But if somebody is really highly transfusion dependent or EPO high, they probably are not going to respond to that. Now, this is the medalist. So this is looking at luspa after ESA failure in RS-positive patients. And that was the original registration study that led to the approval, obviously showing 40% almost responses and led to the approval of the drug. In this study, there was no limitation on the transfusion burden, so there were patients with higher transfusion burden. In high transfusion burden, you need the higher dose of the luspatercept. So it's unlikely to see a response on the 1 or 1.33. You need to go to the 1.75. The most predictor of response was really the transfusion burden. So those patients that had a high transfusion burden in the medalist study, they were less likely to become completely transfusion independent, maybe 10, 13%. There were some transfusion reductions, and that's why moving luspatercept earlier on made a lot of sense. And this is like emtilistat. Obviously, the IMerge study is what led to the approval. IMerge was randomization between emtilistat and placebo 2-to-1, highly transfusion dependent, both RS positive, RS negative. The study met the primary endpoint, around 40% of the patients becoming transfusion independent with a median duration of 52 weeks. There is a subset of patients, almost around 20%, that had more than 1 year response, where the response could exceed to 3 years. The median hemoglobin increase is around 3.6 grams on the study. There is some possible impact on the disease by seeing some allele reduction that in the mutation burden that correlates with responses, some cytogenetic responses, etc. So I think when you see response to imetelstat, it's durable. And in terms of like obviously the survival or long follow-up on imetelstat, the study also did not look at survival. Neither it was in the secondary endpoint. This analysis was to assure safety that with the imetelstat we are not seeing higher rate of progression to acute myeloid leukemia. In the study, most of it was done ex-USA. There was no follow-up on the survival for majority of the patients, but I think it's safe to say that we don't see a negative impact on increased risk of progression of the disease or survival, because people were worried at the beginning about the principle of using telomerase inhibitors in MDS. The other part with the imetelstat, obviously the original study was looking at ESA failure. So the IMerge was ESA failure, lower risk, transfusion dependent. And as you heard from Dr. Garcia-Manero, we're like shifting the landscape. Now we are going to use luspatercept up front. So how does imetelstat work? Theoretically, there is the mechanism of action is different. There is no overlap in the mechanism of action. We pulled patients from the phase 2. There were a few patients on the IMerge, and there is an extension study. I think it ends to be like 31 patients or 36 patients that were luspa treated on those studies, and you see that the responses are around 31%. So post-luspa failure, imetelstat activity is retained. There is a small number of patients that were ESA ineligible or naive with EPO level high, and the responses were high. In patients where we used this earlier, the responses were high. Where the issue was really, again, as Guillermo nicely explained, in this post-HMA phenomena, the responses will drop down to, again, 14%. Years ago, we published the same thing with lenalidomide. This is a phenomena consistent with everything exactly as Guillermo nicely explained. So at least, we have a proof from this data set that the mechanism of action it's probably different, and that patients can have response to imetelstat after luspa failure. Now, we will be presenting this data in details. This is just sneak peek from the abstract, looking at our real-world data since approval of the imetelstat. We treated 40 patients with imetelstat. You can see that majority of those patients had exposure to luspa as the landscape has shifted. They had prior ESA, some of them, 1/3 almost had HMA. There were patients that were treated with lenalidomide. The average was, imetelstat was used as a third line of therapy, because also this correlates with the time of the approval of the drug. And you can see that we saw almost 38% responses. So almost like exact numbers that were seen on the IMerge study. And the median duration is 185. So this is a little bit more heavily treated patients than what was on the IMerge study, but we are seeing higher responses. Then we tried to look at predictors of response. Dr. Zaidan presented data at ASH that cytopenia on treatment early on predicted response. Very similar story that Mikhail Sakarias years ago published in Del5Q. But we were looking at like baseline predictors. Are there any molecular predictors for the response? Interestingly, we saw that platelet count at baseline, IPSS, and interestingly, ASXL1, that's something Guillermo and I had been exploring more in higher risk, adding venetoclax. Here we saw the same thing, that patient that had ASXL1 mutation, the responses were like 67% almost, versus without 29. Again, this is a small data set, but it will be nice to kind of look at this and see, is there something peculiar for the mechanism of action? Can we learn something from that? We'll be presenting the full set at EHA. Obviously, this is under embargo. So. All right, so I think the most important, obviously, or the reason that imetelstat has always been second-line therapy, that we do see cytopenias, as I mentioned. There is grade 3, 4 thrombocytopenia, neutropenia in almost half of the patients. Most of them are short-lived. Within 2 weeks, they will recover. Most of them happen in the first 2 cycles. If you adjust the dosing, they are very limited. When you look at what do they translate to clinically, 1% febrile neutropenia and no actually increased bleeding compared to the placebo. Some patients, small subset, needed GCSF or platelet transfusion, but it's not ongoing. But it's very important, obviously, to follow what was done on the study. So if we see cytopenias, we hold next treatment till the platelets, for example, are more than 50. We dose reduce if they get a grade 4 from the first occurrence, if it's grade 3 from the second occurrence, to follow the package insert. In real life, with the patients referred to us, I've seen few things. So I've seen people start emtilistat with counts that were not eligible on the study. So the study required platelets above 75, ANC above 1.5. I may get soft and allow 50, to be honest, sometimes in practice. But I've seen patients with platelets of 20, they were started on emtilistat. That's not appropriate, probably, and those patients may have a problem. Then the other thing, after the data from the cytopenia correlates with the response, some are pushing the treatment through, that they do basically regardless of the count, this is correlating with the response. That cytopenia correlating with response was in the context where we dose adjusted and backed off the dosing. So it's important still for the safety to follow it. If I see cytopenia, I tell the patient that probably this is a sign that you could respond, but we still cannot start cycle number 2 till your counts improve. And if you hit a grade 4, it's automatic dose reduction. If you get grade 3 and this happens again, then we'll dose reduce, etc. So it's very important from safety point. And when we do that, in our experience, really, we are seeing even less cytopenias, and we saw 0 febrile neutropenia in 40 patients. And this is what I was talking about, Dr. Zaidan data showing a 50% platelet reduction, or more than 75% in the ANC correlated with response. And they looked at this in different ways, and it all kind of was predictive for response. All right, so a case here. This patient is 76-year-old lady, transfusion dependent, RS positive, SF3B1, serum EPO at baseline 380, started with luspatercept, achieved meaningful reduction in red blood cell transfusion dependent. However, after a year losing the response, hemoglobin is 8.2, platelets 180, ANC of 2000. So the question is obviously how we are going to treat this patient. So an RS positive, luspatercept upfront, 1 year response, now losing the response. We continue the luspatercept with dose optimization, switch to ESA, switch to emtilistat, switch to ESA with a brief overlap during transition, or not sure what will be the next step. All right, so majority will shift to emtilistat, and switch, or the small subset will switch to ESA. I think some assume that maybe a patient was on suboptimal dose of the luspa. So obviously, if the patient is not on the maximum dose of the luspa, that's the first step. Emtilistat is very appropriate. We had a small set of patients where we actually added ESA at time of luspa failure. You can get a little bit mileage out of it. But the important predictors were if somebody had no response to luspa, there is no value of adding ESA. If the serum EPO level was high, there was no value. And what you'll get out of it is small mileage. By the guidelines, obviously, emtilistat is the next treatment. And I think I did well on time as well. So I'll pass it to Dr. Carraway. So thank you.
Thank you for that, and thank you for keeping us on time so I don't have to sweat it out over here. You guys have been great, and it's truly an honor to be a part of this evening's presentation. I get to talk about tailoring treatment to patient needs and next steps in higher risk settings. So we focused a lot on the lower risk situation and really talking about transfusion independence and how do we get there. So now we'll kind of talk a little bit more about some of the questions around high-risk MDS and the impact of baseline mutations, and some of the questions that come from the community of physicians that they're challenged with and wrestling as they take care of our patients in the community. So for example, in patients with higher risk MDS who are not able to go to transplant, assuming that there's no targetable mutations, are you routinely going to HMA single agent or DEC-C? And do you consider adding venetoclax? And so this is a big question that, of course, is in our field, and we're probably going to need to have to address some of the questions in the Q&A around this. And I will do my best to kind of walk through the data and some of the interpretation of the results and why we still think venetoclax is an important consideration in our patients. Additionally, we wrestle with, should patients with high-risk MDS undergo repeat molecular testing at progression to reassess prognostic and targetable mutations? And I'm in favor of this. I think we certainly know about clonal evolution as well as clonal regression. So we really need to know what we're dealing with as patients' disease changes with time. How much does the presence of TP53 mutations change your treatment approach and routine practice? And I think this is also ripe for discussion, and we'll talk a little bit about some of the algorithms that we have and why we choose and select therapy around the presence and absence of TP53. Additional questions are around, are there insights on why efficacy patterns with HMA-VEN seem different in AML as compared to MDS? And why might that be the case, and how might we adjust the treatments that we use for patients that have the diagnosis of MDS as compared to AML? Additionally, if a patient experiences stable disease with HMA treatment rather than a formal response, is that enough to justify continuing therapy? We'll talk a little bit about this. Other questions include, how many cycles of HMA do you typically administer before deciding whether to proceed to transplant versus continuing with that HMA-based therapy? And how comfortable are you using oral DEC-C before transplant? And I'm talking about DEC-C as decitabine, cedazuridine, just so that I can be a little more efficient. So when I talk about DEC-C, you'll know what that is. So some of the things that really help us as we look at our patients and think about their therapy and or the need to be a little bit more eager to move to an HMA approach is really thinking about what are some of the clinical features that help us know that we're dealing with something that's more aggressive. And certainly we know that increased marrow blasts have a higher likelihood of transformation to AML, that poor risk cytogenetics or adverse molecular features are associated with inferior survival outcomes. And severe or progressive cytopenias, as you've heard from both Rami and Guillermo, when we have more than just anemia, when we have concurrent neutropenia and thrombocytopenia, we're worried about those patients. We're worried about the fact that they may have increasing transfusion requirements, as well as complications like infection burden. And then obviously in patients that have HMA refractory disease, there really are limited duration or durability of standard therapies. And in that setting, we know even with lower risk patients, their median overall survival is, quite short, typically 14 months or so. And in our high risk patients that are refractory to HMA-based therapy, it's 6 months or less, based on several data from Elias Jabbour as well as Thomas Prébat. So here you can see examples of some of those high-risk mutations, TP53 highlighted there, as well as EZH2. We don't talk about that too much, but it certainly is an important mutation to be aware of, as well as the RAS pathway mutations that we tend to associate more with progression to more a leukemia phenotype, if you will. And then part of this is also inclusive of, other genes such as RUNX1 and or highlighting the fact that we need to think about germline predisposition states in our patients with MDS, particularly if patients are young, namely under the age of 50 or have co-occurring cancers. So that's just a shout out, and I think those patients with germline predisposition states, their bone marrows can look more dysplastic and or strange, and the management of patients may be different. Another example would be the DDX41 mutation that when present, the IPSSM kind of makes it such that these patients are higher risk when in fact the IPSSM is not a great model to use for patients that harbor a DDX41 mutation. So the devil is in the details here, and we will probably argue and fight about some of these things together in our MDS community and talk passionately about them. We also think about what should we do for patients with the diagnosis of MDS that are candidates for transplant. And Rami mentioned this earlier, even in patients that are not responding in the upfront setting, to not wait. Those patients, if they're not responding in the upfront setting, those patients we worry about, and we want to move to curative intent, such as transplant, sooner rather than later. So for those patients, we typically do want to think about a clinical trial followed by transplant. For some patients, of course, we're going to be using an HMA-based approach, such as AZA, decitabine, or oral Dex-C, plus or minus venetoclax in select patients, and we'll talk a little bit more about that in the upcoming slides. And then we also have, in the first-line setting, the opportunity to think about IDH1 mutated therapies, such as ivosidenib, plus or minus azacitidine, or olutasidenib, plus or minus azacitidine, and or in the IDH2 mutated setting to use enasidenib. And I will just shout out in this setting for IDH1 targeted and IDH2 targeted therapies, we're really using those in the first line setting for patients that are not candidates for kind of aggressive type approaches. That being said, I think our community practice and our clinical practice is wanting to use these agents because they're well tolerated. Patients respond to them within 1 or 2 cycles, and patients typically, for some of the patients anyway, their neutropenia actually resolves quite quickly and decreases their risk for infection. So it makes these options very, very important. I think the caveat, of course, is that the number of patients with these IDH mutations is less than 10%. Importantly, though, these are patients that should be identified because as patients get older, the likelihood of these IDH mutations increases. And so again, underscoring the importance of repeating testing, particularly as there's clonal evolution. I think these are very important drugs for our patients. I wish we could use it in more of our patients, but hopefully with time, we'll find opportunities. Finally, we don't talk as much about high-intensity chemotherapy. This can be an option for selected patients and for the right patients, and many of our transplanters really favor us getting optimal control for patients. We have a lot of discourse about whether or not high-intensity chemotherapy really changes the biology of MDS versus just clearing out the blast percentage and allowing for disease control vis-a-vis blast percentage before transplant. And when we think about the majority of our patients diagnosed with high-risk MDS, many of them and the most of them will not be transplant candidates. And you can see here then, as a result of that, we're using preferred AZA, decitabine, or oral Dex-C in this patient population. And then useful in certain circumstances, I think we've walked through the IDH1 or IDH2 mutated setting, as well as a consideration for venetoclax plus an HMA backbone, again, with certain circumstances, and we'll talk through that. For those of you that don't or aren't familiar with the data that show the improvement in overall survival for high-risk MDS patients that go to transplant, this is the BMT-CTN study that led to us showing that there is an improvement in patients that are over the age of 50 that had a donor and versus no donor. So in this particular study, you can see to the left, for those high-risk MDS patients that were able to go to transplant because they had a donor, you could see there was an absolute improvement in their overall survival to the tune of 21%. And the graph to the right is actually showing you the benefit of having a donor. And anything that is graded above 0, that means that there's a benefit in having a donor and going to transplant. Anything that is below the 0 line tells us there's a benefit to not getting transplant. So you can see that in the solid line, you're seeing that solid line is increasing, showing us that over time there is an improvement for those patients that ended up receiving a transplant. Importantly, you can see the 95% confidence interval above and below, and that tells us the confidence that we have with that line being true. So you can also appreciate that there is a downward trend in the initial part of that curve, and that's probably because of BMT-associated morbidity and mortality. And with time, that continues in the upward direction. You can see that the estimate at the 3-year time point lands in that 21 percentile range. I thought that figure was somewhat confusing, but then once I walked through it, I was like, oh, this totally makes sense, and it's nice to see. Again, when we look at HMA-based therapy, it is very exciting to be able to have oral options for our patients so they're not needing to come to clinic in order to get sub-Q or IV injections. And this study led by Garcia-Manero really helped us to understand that there's a bioequivalence and a benefit to, or potentially being able to use AZA along with cedazuridine in an oral format versus sub-Q azacitidine. The primary endpoint to this study that enrolled patients with MDS, CMML, and even AML randomized patients to a 1-to-1 to receive either the oral pill versus sub-Q AZA, and then they flipped. And the endpoints to this study was really looking at the area under the curve for those patients that received these agents over 21 cycles. And you can see that ultimately the goal was to see, do we have the same amount of area under the curve or drug exposure to these patients that receive this drug? And ultimately, the other thing I wanted to point out here is that there were 30 patients that were enrolled in this study. The majority of the patients on this study were MDS patients, probably 20 to 25 patients, and the minority of patients were AML patients. You can see that the toxicity to this drug was manageable. Most GI events were grade 1 and 2 and were well managed with antiemetics, and that's expected for this particular drug. And nearly all patients received antiemetic medications, either prophylactically or therapeutically. Other adverse events were expected with regard to hematologic toxicity, namely neutropenia and thrombocytopenia. And ultimately, this study was able to demonstrate that the fixed AZA-C regimen was equivalent, if you will, to the sub-Q injection of azacitidine. Interestingly, though, when they looked at the BSA for each of the patients, the optimal dosing looked to be different for different BSA subsets. So, for example, the high BSA patients needed to receive the azacitidine dosing of 175/20 versus those patients that had a lower BSA. And this now is being moved forward and actively being investigated in the phase 3 study, as you see here. Now let's turn to the Verona study. Unfortunately, the Verona study did not show that there was any significant difference in overall survival between those patients that were randomized to AZA-VEN versus AZA plus placebo in intermediate and high-risk MDS. Importantly, though, you can see to the left that for those patients that received Ven-Aza compared to those patients that received placebo-Aza, there was a higher overall response rate and improved transfusion independence rates that you see to the right. Importantly, as you look at red blood cells and platelets with regard to transfusion independence, there was a higher rate of HI for those patients that received combination. I think the other important point here is that for those patients that received combination azacitidine and venetoclax, that particular arm had significant dose modifications to the tune of about 30 to 50% of patients had a dose modification of their azacitidine. And despite that dose modification, there still was no difference in overall survival. So there's some lessons learned historically that we've had with regard to azacitidine and or decitabine and or Dex-C, that patients need to continue to be exposed to this therapy and tolerate it. And the way that this study was designed and kind of insisted, the FDA insisted that the dose modification needed to happen with AZA before any dose modification of venetoclax. And I think we'll talk a little bit about this in the Q&A session. Many of us in real world practice may change the dose of venetoclax in favor of changing the dose of AZA-based therapy or HMA-based therapy. And so those are some of the things that are important to tease out, I think, and we continue to learn more and ask questions in this vein. Importantly, there were some things that we could learn from certain subgroups in this study. There were signatures, if you will, that certain populations may have done better towards the benefit with combination Ven-Aza, and namely those were patients that were aged less than 75 years of age, those patients that had higher blast percentages, those patients with higher, very high risk IPSSR, and then some specific mutations at baseline. Again, we see this ASXL1, we see TP53, and we see a RUNX1 here as well. So this, I think, remains something that intrigues us and I think really impacts some of the clinical practice in the real world with regard to whether or not we're adding venetoclax to our patients with HMA-based therapy. With regard to retrospective analysis and real-world analysis, you can also see here validation of some of this experience across 19 U.S. academic centers evaluated adults with higher-risk MDS that were treated with frontline HMA-ven or HMA alone. And you can see that there was an improvement in overall survival, including patients with blasts, again, that were higher, patients that were diagnosed with de novo MDS that ultimately went on to have a transplant, and also those without TP53 mutation. So if you look at the graph, it's a little tricky. You can see ASXL1 mutated, those patients benefited, and in the chart there you can see TP53 unmutated. So don't be confused by that, right? I wanted to read that as TP53 mutated, and it's not. Importantly, moving things forward and taking lessons learned from the Verona study is this ongoing phase 3 Gloria 4 trial that, again, is led by Garcia-Manero, is assessing another BCL2 inhibitor called listofoclax and using it in combination with azacitidine in our patients with higher risk MDS. Patients, again, are randomized to listofoclax plus azacitidine versus placebo plus azacitidine. The primary endpoint here is overall survival, and the secondary endpoint being safety based on the AEs. So in general, I thought this was a nice algorithm to kind of go through, and this is a shout out to Rami here. This is kind of stolen from one of his publications, and you can see just a modern pathway adapted for the treatment of higher risk MDS. And we've talked a little bit about when patients are diagnosed with high risk MDS, the first question we want to ask is, are they a candidate for transplant? If they are and they have low burden disease, you can proceed directly to transplant. If they have higher burden disease, then you need to think about how you're going to manage that patient and get them to transplant safely without complications of infections and or causing other toxicities to their liver or other organs that they might need as they remain eligible for transplant. If they are not a transplant candidate, we then think about whether or not their disease harbors a TP53 mutation. If so, we really favor using an HMA-only approach in that particular patient population based on the fact that there has not really been any added benefit to the addition of venetoclax to that particular patient population. And we argue about that a little bit in our own institution, particularly if those patients are headed to transplant. We try to want to get them to transplant, and if we don't want to stand in the way of not doing everything possible to try to get them there. For those patients that do not have a TP53 mutation and have some of those features, as we talked about earlier, such as high blast count, ASXL1, we may then consider using venetoclax and adding that to an HMA backbone. And then other considerations obviously include a clinical trial for our patients, and that's particularly important in the high-risk MDS pathway, and many of you know the work that's been done over the last number of years looking for combination therapy in our patients with high-risk MDS. So ultimately, when transplant is not an option for a patient like Max, who's 68 years old with newly diagnosed high-risk MDS with progressive fatigue, reduced exercise tolerance, and easy bruising over several months, with a blast percentage of 9%, presence of multilineage dysplasia, and molecular profiling of ASXL1 and RUNX1 mutations, you can see their IPSSM is high risk and there's no matched donor currently identified. You can see the complete blood count there with anemia, thrombocytopenia, and a preserved neutrophil count above 1,000. So in this particular patient, we would say that this patient warrants timely initiation of therapy. We're not going to sit on this patient and wait and kind of think about what to do next. HMA-based approaches in this type of patient, plus or minus venetoclax, can be considered while waiting for donor identification, and treatment planning should incorporate transplant candidacy, molecular risk, and donor availability in consideration for what to do in the post-transplant setting to even decrease any kind of likelihood of relapse. So with this, I'm going to move to the next slide that's going to prompt you to pick up your phones, and for a transplant-eligible patient with high-risk MDS, ASXL1, RUNX1 mutated, who requires timely therapy while awaiting donor identification, which strategy would you most strongly consider? HMA-based therapy, HMA plus venetoclax-based therapy, intensive chemotherapy, or clinical trial enrollment. So about 2/3 of you voted for HMA-ven-based therapy and probably kind of were listening intently as we talked about some of those features. Some may favor intensive chemotherapy, and I'm happy to see some of the clinical trial enrollment that, of course, is appropriate for all of our patients with high-risk MDS. And with that, I think we'll move to the next slide and turn things over to Dr. Garcia-Manero.
Thank you. That was really fantastic presentation. And I think we have a few minutes for questions. Go ahead. I think we're going to ask for the microphones so people can.
Thanks very much for such a well-organized talk. I'm Blossom. I see some MDS patients at Fred Hutch. I had two questions. The first, Dr. Komrokji, you mentioned low-risk MDS patients going to transplant if they had failed several lines of therapy. Could you tell us a little bit more about your experience with that and when you send these patients to transplant?
Right. Yeah. So obviously, historically, like if you look at the lower risk MDS, their cure rates are higher actually with transplant, right? We probably can approach 60-70% cure rates compared to the 40-50 in the higher risk. But it's always the trade based on those Markovian analysis or decision that the maximum gain is to wait because you don't want to take the transplant mortality in the first 1 or 2 years. But if a patient, like when we looked in our data set, if patients had 2 or 3 lines of therapy failure, the chance of response to anything after that is probably less than 10%. And their survival becomes in the range of 2 to 3 years. Like as Het even mentioned, like years ago we did this with Elia and Guillermo, looked HMA failure lower risk, 18 months. I think that's in the range. If you do those decision analysis models, you'll see that the maximum gain for survival for these patients is to go to transplant, particularly younger patient. We are doing the same thing now even when we apply the IPSSM, some of the lower risk patients. If they are upstaged by the IPSSM, the younger ones, I'm thinking of transplanting them earlier. I think we are better identifying donor. Probably the transplant-related mortality is dropping down. So I think younger patients, it's definitely curative therapy. So I usually do it after 2 to 3 lines therapy failure. If somebody does have higher risk features by IPSSM, they're younger, those are the patients I think of transplanting.
Thank you. And the other question I had is, for those RS-positive patients who are failing ESA, luspatercept, and imetelstat, are you going to lenalidomide for them, or you prefer an HMA? It depends on whether they have concurrent cytopenias.
Right.
What's your practice?
Yeah, like I don't think we have data on len after imetelstat because what you are alluding to historically, we used to use len even in the non-del5Q, and Dr. Santini published this data, 25% responses, which is sometimes reasonable, right? When we looked in the past and the sequence after HMA, that drops below 10%. Before HMA, it was like around 25%, similar to what Dr. Santini reported. So post luspa, imetelstat, we don't have data, and if they had HMA, definitely I don't go to len. Sometimes we go to len in the MDS, MPN, RST, and we've published this also together, that there's like 40-50% responses. So I think it's kind of, imetelstat had replaced a lot of the len, especially obviously in the non-del5Q.
Those are really great questions. I think it reminds me of the S0007 study that Mikhail did, that one of the arms was AZA, the other arm was AZA-len, and the other arm was AZA-varinostat. And interestingly, of course, there was no difference in any of those arms, except there was a trend in those patients with CMML
right,
that did have a benefit with combination of AZA-len, although those numbers were too small to really hang our hat on. But in that rare instance, that would be something to think about. But I think it would be really hard to justify adding len after ESA, Luspa, and imetelstat. I agree.
Right. I think one of the interesting data, sorry, I mentioned, you presented, and you probably can allude to that more, like the dual IRAK inhibitors, like that are in development. I think if we have those studies, like that's what we'll start offering patients after those therapies fail, because even in that, I'll let you talk more. Because
no, go ahead.
No, go ahead.
Okay, no,
like it's really looks like probably the most promising, where you are seeing 20-30% at the beginning. People may dismiss that, but if you look at that population, that's exactly probably what we are going to be dealing with, which is going to be the next step, that we are going to see patients post-luspa, post-imetelstat, maybe HMA. So maybe you can summarize the data more.
So these patients have this kind of innate immune deregulation. There's directed toll receptors, this IRAK4, 1, MYT88, NF-kappa B, and then downstream. So blocking this pathway could be quite effective. So what Dr. Komrokji is alluding is drugs that are very selective inhibitors of this IRAK4. There's some, but they also block like FLT3, click, so they're very cytopenic kind of inducing agents. There's one particular agent called R289 that is very, very selective, and this drug has actually no cytopenia. And this pathway is particularly engaged in this HMA failure patient. So I agree with you. I think we need to move into combinations, though. Like in the future, probably you will have a combination of some of these agents, they kind of cross-talk up front, and maybe, as we started in the session, if we can get 100% responses right, then maybe it would be better off than what we achieved right now. But you work in the best transplant program in the world, right? So at MD Anderson, if you have intermediate risk disease and you are transplanted, your cure rate is significantly better than anything that we discussed. So sorry for the sponsors, but the reality is there is a role for some younger individual that for whatever one reason or the other, you may think is a candidate for transplant. So very low risk disease, maybe that's kind of aggressive, but once you move into intermediate risk disease, this is actually a very significant transplant benefit. And the beauty of this is that you don't have to treat the patient, you just go and take the patient to transplant. The indication will be today, I guess, HMA failure, maybe imetelstat failure. Yeah, so I think we ran out of time. There are more questions, so I don't know for the organizers, what should we do? We do a couple of questions or we close? Anyways, so it's been a pleasure to be here. It's been a lot of fun and learn from you guys. And thank you very much for this opportunity. Thank you.
Thank you. Thank you.
Thank you very much.